Good afternoon, everyone. My name is Dr. Ryan Mabes. I'm a professor of medicine and anesthesiology at Wake Forest University in Winston-Salem, North Carolina. Welcome to the CHEST COVID-19 webinar series. It is my distinct pleasure to be here today discussing updates in vaccines for SARS-CoV-2, both strategies for the clinical management of patients, optimizing vaccines for different populations, and also strategies to address the ongoing challenges we have in clinical practice with vaccine hesitancy. I'm joined today by Dr. Susan Klein, who's professor of medicine and director of the Division of Infectious Diseases at the University of Minnesota, and Dr. Joe Cabaza, who is pulmonary and critical care at the Cleveland Clinic. We're going to lead off with Dr. Klein, followed by Dr. Cabaza, and then we'll come together for a longer discussion. We'll be able to address both audience questions, the questions you've submitted in advance, and to see where the conversation takes us. So first, I'd like to introduce once again, Dr. Klein.
Thank you, Dr. Mabes. So I'm just going to share my screen now. So today I'm going to be talking with you about booster doses for the COVID vaccine primarily. And, why are we talking about the booster doses now? I think because we're really in a somewhat unexpected position. We're in this perfect storm that we're seeing waning immunity from vaccines from people who were vaccinated early in 2021. And now we're having this Delta variant surge, which is occurring in the second half of this year in our country. And these two things combined are leading to decreased vaccine efficacy. And so I think we are now learning from the studies that are coming out is that we're seeing more breakthrough infections, and we know that antibody levels fall over time. And so I just wanted to review some of the current data that we have, which I think helps guide us in making decisions about booster doses. So this was one of the first reports that came out, and this was published in the MMWR in August of this year, talking about the effectiveness of the Pfizer, BioNTech, and Moderna vaccine in nursing home residents, and comparing the time periods before and after the widespread circulation of the Delta variant. And this data showed that early on, the vaccines in the real world setting looked quite efficacious, even in this elderly nursing home resident population. 2 doses of the mRNA vaccines were 74% effective against infection. And that was in the time period March through May. So this is recently after vaccination. But when you look forward to the time period June through July, when the Delta variant was circulating, and after time had elapsed since the original vaccination, the efficacy had dropped to 53%. So dropped about 20% during this time period. And then there was another report that came out in the Morbidity Mortality Weekly Report in August, looking at new COVID-19 cases and hospitalizations among adults by vaccination status in New York State. And this looked at the time period May through July of 2021. And what they saw is that the age-adjusted vaccine effectiveness against infection declined during this period by about a little over 10%, from 91.7 to 79.8%. But if you look at the effectiveness of the vaccinations against hospitalization, it was still relatively stable and quite good, from 91.9 to 95.3%. And then the same month was published this report of the effectiveness of the COVID-19 vaccines in preventing SARS-CoV-2 infection among frontline workers before and during the Delta variant predominance. And this was in 8 US locations from December 2020, when healthcare workers first started getting vaccinated, to August 2021. And here again, they saw that overall vaccine effectiveness fell during that time period. Initially, it was 91% before predominance of the SARS-CoV-2 Delta variant. But if you look at the period where Delta was predominant, vaccine efficacy fell to 66%. And so I think, that was concerning, of course, that our frontline workers now, a little over 8 months after their initial vaccinations began, were already having significant decrease in the effectiveness of the vaccines. And this is a study that was reported, more recently, looking at veterans. And this is looking at protection of infection. And this slide in particular is showing survival in US veterans based on their vaccination status. And these graphs are a little busy here, but let's just look at this panel D, and I'll go through these lines. So this is looking at survival in weeks of follow-up. And you can see the group that has the lowest survival is that light blue line, which is unvaccinated and PCR positive. So if you haven't been vaccinated and you're infected with SARS, you have the worst survival. And then the black line is unvaccinated PCR negative. And then the next line up is fully vaccinated and PCR positive. And then the best survival overall over a 26-week period of time is the group of veterans that are fully vaccinated and PCR negative. So, I think this graph shows two things. One is that survival over time is falling, but also that the group that was vaccinated has better survival. And this is a graph just showing how the antibody levels decline over a 6-month period of time. And you can see here, this is like a month after the initial vaccination, antibody levels are quite high. But I just want to point out this graph up here, A, and you can see that the levels of antibodies vary based on the particular strains that you're looking at. And the lowest antibody levels in this graph are actually in this red strain here, which is the beta variant. So this does show that antibody levels that can neutralize the virus vary against the different strain types. And I think that's significant now that, we're hearing about this new Omicron variant, and we're not sure yet what those virus neutralizing antibodies will be from the prior vaccinations against the Omicron variant. And so, what is the data to support the booster dose? So, most of the data we have is based on increasing titers and virus neutralizing titers. And we know that after boosting, those titers go up. And yet, do we know what the real world data shows us? And I would say that in this country, we really don't have that real world data yet. But I think Israel has reported some very interesting data. So in Israel, they started seeing breakthrough infections early on this summer. And they compared case rates in the elderly in the summer of 2021 compared to the winter and spring, which was shortly after the initial vaccination series. And they saw these breakthrough infections were rising in the 60 and over group, and that some of these patients were getting seriously ill and were being hospitalized. And so they decided early on in Israel to start offering boosters to those 60 and over. And pretty quickly, they started seeing that cases were falling. And they've now published some of this data in the New England Journal of Medicine. And so this table is showing some of that data of giving the booster dose against COVID-19 in Israel and what the difference are in outcomes. So if you look at this non-booster group and you compare it to the booster group, the non-booster group, and this is over 5 million patients, had 4,439 breakthrough infections and 294 cases of severe illness. But if you look at the group that was boosted, they had a fraction of the number of cases. They had 934 cases per 10 million people, so a larger group and significantly fewer breakthrough infections. And then if you look at the group that got boosters and had severe illness, there were only 29 cases of severe illness. And so that was a tenth of the non-booster group, and you're dealing with a larger denominator. So based on this Israeli data, it looked like, the booster dose really was effective at preventing breakthrough infections and severe illness compared to a non-boosted group. And this slide is just showing some of the antibody data, looking at neutralizing antibodies in patients who had had 2 doses of the Pfizer vaccine and comparing that to just before the 3rd dose and after the 3rd dose. And on the top table here, you can see in green, this is the typical strain that we had, and then the orange is the beta variant. And so you can see that these antibody levels fell from a month, month after the 2nd dose until just before the 3rd dose. And then after giving the 3rd dose, you had a nice boost in antibody levels, not just against the original SARS-CoV-2 strain, but also against the beta variant. And I think this is important too, because I think this gives us some evidence that the existing vaccines give us some protective immunity, even against these newer variant strains. And in the bottom picture here, it shows the neutralization of wild type virus in the Delta variant. And you can see that the levels here of the wild type compared to the Delta are actually quite similar, and that they are boosted to both of the strains after the booster dose. Now, this is the data that was done looking at this issue of mix and match boosters. And that's something that I think people are quite interested in. And this was a study where they took people who had had primary vaccination with the 3 different vaccines in this country, the Pfizer, the Moderna, and the Johnson & Johnson. And then they boosted these people with a variety of booster doses. So some people in each of the categories got the Pfizer booster or the Moderna booster or the Johnson & Johnson booster. And basically what they saw is that the Johnson & Johnson vaccinated people started with lower antibody titers across the board. And if they were boosted with Johnson & Johnson, they did get a boost, but not as high as if they got a boost with one of the mRNA vaccines. So both the Moderna and the Pfizer vaccine boosters after the initial J&J gave a stronger antibody response. And if you compare with the mRNA vaccines, boosting with Moderna versus boosting with Pfizer, the Moderna booster actually got the strongest antibody response overall and was a little stronger than the Pfizer. And this table is just looking at this issue of immunocompromised patients. And this is in particular looking at solid organ transplant recipients who had 2 doses, comparing those to recipients who had a 3rd dose. And you can see that overall, the number that are seropositive after 2 doses is really not that good. And after the 3rd dose, you've significantly boosted. And so now you're over 50% of your recipients who have good, what we hope are protective antibody levels. And these are just the references that were used for that. And so, based on those studies, the FDA came out early on in August and said that they authorized an additional 3rd vaccine dose in persons who have undergone solid organ transplant or are diagnosed with conditions that are considered to have an equivalent level of immunocompromise. And so they went on further to say that it really should be a 3-dose primary series. And probably I'll just stop with the slides here, Dr. Maves, because I think I'm over my initial time, and then we could open it up for questions.
Not over at all. Thank you very much, Dr. Klein. That was wonderful. Next, we're going to turn it over to Dr. Cabaza, who will discuss some issues regarding vaccine hesitancy at the bedside for a practicing pulmonary critical care physician. Dr. Cabaza?
Yeah, so thanks, Dr. May. Thank Dr. Klein for those that great, helpful information. It's great to have a lot of infectious disease minds helping us, because a lot of that was way above my head before this pandemic, and kind of getting comfortable with that kind of research and data has taken a little bit of time with everything else going on. But, I think in pulmonary and critical care, we have a very unique position in healthcare right now, especially within this pandemic, is that, we span both worlds. We come across patients in the outpatient setting, in the office. We get to know them, have relationships with them for years. And we also are kind of eyewitnesses about what's going on in the intensive care unit, sometimes taking care of these same patients that we've known for years in the ICU. And I think pulling in our experiences from what we see in the hospital and bringing it to patients we come across in the office, I think gives us a little bit of an advantage in trying to have some of those kind of pushes for the vaccine hesitant. It's talked about as grassroots, where it might be easier to go one by one with the patients and trying to reach people directly with all the misinformation and noise going out there. And I was really, I think in February, March, April, I really felt, maybe arrogantly, that I'd be able to convince every patient I met to get vaccinated. And it took me a couple of weeks till I realized that was not really feasible, and also how challenging it was emotionally, where people I've known for years that I thought I knew or that trusted me certainly suddenly felt they knew more than me about complicated aspects of medicine. So that was a bit humbling and kind of really pushed me back a little bit, where I went through a phase where I wasn't really asking any patient anymore. I didn't want to experience that potential confrontation or the backlash or even the rejection of talking to them and having them tell me, well, no, I'm still not going to. But it was exciting. February, March, April, so many people were getting vaccinated, so many less people were dying and less people in the hospital. And then we go into June and July, and the cases were so low. And I didn't really talk about vaccines much after all. I kind of thought we'd seen the worst of it. And then Delta came, where kind of that push of just cases in the community that filtered through the hospitals, and that we're still, we thought we were going down a little bit, and now that bump back up has really, I think, brought it very important again to kind of not only talk about vaccines to the unvaccinated, which of course is the priority, but now to make sure that our vaccinated people are getting boosted, because there are a lot of patients who got their 2 shots, but either are not aware or confused or perhaps not convinced that they need to keep up with it. They got their 2 shots and they feel like that's it. And that might be enough for a lot of people. But I think the big theme is that, especially with a lot of questions that patients have, is just we don't know. And I know, natural immunity questions certainly do come up, and we just don't know. Natural immunity is very good, probably for a bunch of people, but how do we know which person it's good for and for how long and against which strain? And so, the whole really theme point is that what we tell everyone is more immunity is better than less. So whatever you have now, if you get more of it, you're going to be better equipped for whatever might be around the corner, and to get as much immunity as you can the easy way. I think recently, as at least at our institution, when we're about to implement a mandate, I've had many coworkers come up to me with questions about vaccine, and you kind of learn. I've really learned so many people I work with. We're not really anti-vaccination, but more really just either scared of side effects or on the fence, or kind of put it off so long that they're almost embarrassed to ask questions about it, even of their physicians and even coworkers. And there are people that I've known for years that I wish they had came up to speak to me sooner. And really the vast majority, in my experience, have, after just an honest face-to-face conversation, answering their questions and reassurances, have gone on to get vaccinated. And really one of those that feels like really just a huge victory anytime somebody chooses as a result of the discussion. But, the office has certainly been a challenging spot because you have patients who are afraid of being judged also. Some are ready to have a confrontation when it comes up. And then there's a subset who are certainly on the fence that are just a little scared and might need a little bit of a nudge. And I really, what I now do, I oftentimes just, in general, I will just talk about my experience in the ICU, in the office. I'll just make a line about how, last week was a nightmare in the ICU. We're just seeing some terrible, heartbreaking stuff. Really just, draw about my experiences. This isn't a TV show. This isn't, some other state or other country sharing their experiences. This is an ICU doctor that they happen to be sitting across in the outpatient visit from, just casually talking about how bad things are around the corner from them. And that oftentimes really, it puts kind of people at ease. I did not bring up vaccine. I didn't ask them about vaccine. I'm just talking about really tough stuff that's going on around us. They'll sometimes ask about vaccination of those patients. I generally will add that it's sad how preventable things are now. And really, I just draw on what I'm seeing in the ICU. And I think that gives us pulmonologists who practice ICU or even inpatient medicine, I think a very strong advantage in that we see everything and we span all aspects from the mild outpatient illness to those who are severe ARDS on the ventilator and who don't make it. So I do see it in their eyes, that trust, that they just say, wow, this is somebody who's seeing everything and not trying to scare me, not telling me any story. They're just, I don't know any state statistics. I don't know national statistics. I barely even know my county. I just know what's going on in the ICUs that I work in. And I think that helps them a bit also, just really drawing about just really what I see on the ground level. And I make it very non-judgmental as well. I'll ask them if really, and I don't ask them, are you going to get vaccinated? Did you get vaccinated? That I found people find they get a little defensive with that question. Some really jump down your throat when you ask it that way. And I just ask simply, do you have any questions about the vaccine? So some people will say no right away. It doesn't really give them an opportunity to even have an exchange about it. If they say no, then I'm kind of done there. I don't really add much. And by me not adding much, it almost puts them at ease a little bit. You could see them kind of loosen up and relax a little bit. But what that does, it gives me an opportunity when I see them next in a few months to then reintroduce it, because they know I'm not judgmental. I'm not pushy. Granted, I wish I could give it immediately to everyone. But I think that pushing approach also may push some people away. And I think realizing this is a really a long road, and getting to the people who don't have questions or who are not hesitant or just really opposed to it, if if you're not telling them what to do or what they should do and just leaving it at, do you have any questions? I find that kind of softens them up for the next time. I see them in the office where they're more willing to have an engage because they know there's no judgment from me. They know that it's going to be just an honest discussion. I tell everyone how I treat my own family members is the advice I give to patients. And there's certainly all sorts of different lines I use when talking to patients. I'm really trying to pull onto the fact that, we would not do anything that we think would be harmful or risky to ourselves, especially to our family members and loved ones. And but I think I always try to plan on that next visit. I think if they're not there with me mentally to make that to either even ask questions they have or share their thoughts, knowing that I'm not pushing and not judging does open them up for future visits where I think the odds of having a healthy exchange become better. And also, I think most of the hospitals now are offering vaccines to inpatients. And so when I'm taking care of any non-COVID patient in the hospital who's not vaccinated, I do ask them about vaccine while they're in their bed, ask them if they have any questions, where they're there face to face and they're scared in the hospital about whatever they're in there with. I found that as an opportunity to be able to talk to them about ways to prevent them from being in the hospital for COVID in the future. And I wish I kept statistics, but I think my hospital acceptance to initial vaccine rate continues to be pretty high, a lot higher than I really imagined. And I think it's the combination of them being in a compromised position. They're in the hospital for something else, and to kind of talk about easy preventive ways to keep them out of it and a chance to answer questions they may have. I think early on for non-COVID patients in the hospital, I was not having that dialogue, at least at the very beginning. And also we did not have vaccines at least at the very beginning, earlier in the winter. But as that's evolved, trying to catch people wherever they're at in the hospital, I think is a good place to handle some of those inpatients who are vaccine hesitant. And that aspect was a lot easier than I'd imagined. And I think we just have an advantage because they are in the hospital, because they're scared of whatever non-COVID issue had them there. So it's really been interesting kind of navigating, the outpatient, the inpatient world. And I think pulling our experiences from both can really help us have kind of higher rates of having patients choose to get that immunity the easy way and to keep them from ever, seeing me in the ICU and to just kind of keeping it in the office. I think in the first year before vaccines, I lost 6 outpatients to COVID, 2 of whom I was taking care of in the ICU, who I'd known for years. And since vaccines, almost a year now, I've only lost 1 patient. And she was vaccinated, but had a lot of other issues. But it's, so I just draw on to those real experiences in the office and spanning the hospital. And I really think those of us who span those worlds of outpatient and inpatient really have, I think, a responsibility and also, I think, a strong advantage in this quest to try to get more people immunity to COVID.
That is a great summary. Thank you so much, Dr. Kabaz. And I think your point about the uniqueness of pulmonary critical care practice and the way we interact with patients. Of course, I'm an intensivist, not a pulmonologist, but we, in my outpatient practice is largely transplant ID. Dr. Klein, of course, is also an infectious disease physician. But between the 3 of us, I think, in pulmonary medicine, almost every patient in your practice and in all of our practices are going to be high risk, virtually by definition. There may be occasional isolated exceptions, but they are infrequent, right? Very, perhaps a person with very mild sleep apnea in the absence of a significant challenge with obesity, for example. But by and large, everyone we contend with in our practices, everyone we work with and develop relationships with, are going to be folks who will need potentially a 3-dose primary series, and very frequently will be recommended a booster. Now, certainly CDC is now recommending boosters for all adults, but it is, there's a certain degree of prioritization. I think you were alluding to there, Dr. Kabaz, about there's everyone should get a booster, but who do we start working with first? And actually, one question, this has been coming up in the chat, and if I may, I'm going to first direct this to Dr. Klein, but that we can all talk about it, is a little more on the mix and match practice. Dr. Klein, you showed that study from NIAID by John Beigel and colleagues about the relative impacts of mix and match boosting. In your own practice, what do you think about that? What is your practice been?
Well, in the outpatient clinic, I see a lot of long-term continuity patients with HIV infection.
Mm-hmm. Yeah.
Most of them, fortunately, have been on HIV treatment for a number of years and are doing quite well. But, I've been really encouraging them to get boosted and complete the initial series if they haven't. And, I would say in my practice, most of my patients actually got one of the mRNA vaccines. And so I'm recommending an mRNA booster to them.
Yeah.
And, but if a patient got the Johnson & Johnson, in that situation, I tell them that they could get a second Johnson & Johnson after 2 months, or they could get one of the mRNA vaccines. And both of them look very good. In fact, I would recommend, if they're accepting of an mRNA vaccine, that they get either the Pfizer or the Moderna as the booster after a single J&J. And the other thing, I saw someone asked in the chat, what if they had another vaccine, such as, I think Sinovac was the example.
I'm trying to recall, Sinopharm, I think might be another adenovirus.
Well, Sinopharm, was that it? Yeah. So I think that's one of the Chinese vaccines, but so, you can boost people after those as well. So the current FDA guidance, which came out in the end of October, is that the use of our currently available COVID-19 vaccines in the US as a heterologous boost in eligible individuals can be given with a different available COVID-19 vaccine. So really, they've given us sort of free license to go ahead and boost anyone who would be eligible for a booster with any one of the 3 currently available vaccines. But I would say, based on that study done by Beigel et al. With the heterologous boosts, the mRNA vaccines look superior. So if someone had been given a primary series in another country with a different vaccine, I would still offer them one of the mRNA boosters.
So, it was interesting. When that first data about the relative greater protection of Moderna over Pfizer came out, I think one concept of vaccinology that it takes some time to explain to patients is that the interval between vaccine doses is a minimum, not a maximum. Right, and that we actually, we're with vaccine dosing, we are trying to maximize protection as efficiently as we can, getting all the series into a patient as quickly as we can, but also understanding that spacing out the interval between doses of a primary series tends to increase immunogenicity. And we see that over and over again with vaccine development. I think early on, I had hypothesized that maybe Moderna had a little more oomph to it, slight difference, and probably not a massive clinical difference, but a little more oomph to it because of the longer interval between the first and second doses of Moderna. Maybe waiting a little longer made the difference. But then when we look at that boosting data that you presented, where you still pretty consistently see a little more efficacy with Moderna as a booster, I'm more skeptical of that opinion that I'd held earlier, that maybe it's not that the interval may have nothing to do with it. It may just be a somewhat more immunogenic vaccine. And it correlates pretty interestingly with the antibody titers, which we can maybe loop back to in a minute. But so with all of that, Dr. Cabaza, we talked a lot about approaches to vaccine hesitancy, both with patients and with colleagues. And you alluded to how there are some folks who are on the fence versus folks who are more sort of overtly resistant. What kinds of strategies have you found useful for people who are more on the fence? What have you found their concerns tend to be? Examples of sorts of things you worry about and strategies you found helpful with them.
Yeah, so the concerns for those people tend to be, well, number one, fear of side effects. So really fear of that feeling lousy for a day or two afterwards, where they made it, because most of them have friends who are family members who have been vaccinated. And there's just a big fear of having a flu-like illness a day after a shot or a day or two in bed. And for some people, that's the initial thing keeping them away. And then, just the noise of fear of kind of the more serious complications. So then, I know myocarditis came up, the clotting comes up quite a bit. Infertility comes up, although that, I don't think anything's been shown from that. If anything, I think there's an urgency to get all pregnant women or even women trying to get pregnant immunized, because that's ultimately long-term the best thing for trying to have a baby, is healthy mom ultimately. But so it's really fear of the common side effects, and also fear of the very rare side effects, and then some questions or concerns about the stuff that has not been shown to do anything, well, like the infertility and pregnancy loss and all that. And I try to have everyone just to step back. I tell them, I understand the confusion. It's understandable why they're scared or and pushed it off, because there's so much noise around this vaccine. But I asked them to just take a step back. They're just kind of buried thinking about vaccine, this now. Take a step back. The most common cause of blood clotting and terrible hematologic pathologies of the last 20 months, it's been active COVID infection. So I tell you, if you're going to give a million people a COVID infection and a million people COVID vaccine, those are the two groups you need to be comparing when deciding a decision for you. Because if you're afraid of blood clotting, this virus is not for you.
Yeah.
And similarly with myocarditis, and really almost any, because I think COVID can and has done almost anything. Almost with any fear, you can really just have them step back and just try to compare both groups, and also calling on like what we visually see in the hospital. And then also from the infertility side and pregnancy concerns, we kind of just talk about how those are just not true, and we share data and that our OB colleagues, have not seen any shortage of expectant mothers or deliveries, and the only stories we get from the OB side are losses, mothers, babies who are soon to be born who just did not make it because of a mother's illness with COVID. Those are really the heartbreaking OB stories that it's hard that people forget about, because there's so much noise around vaccines. And I just always have them just step back and look at those two groups. We know, why are we not scared of what happens with the vaccine? Because we're all going to be faced with COVID. So everyone's immune system will be producing some kind of protection or antibodies to COVID. And the question is, do you want it the easy way through vaccination, which is an extremely low risk, versus rolling the dice the harder way from more of the natural infection? And just I try best always to compare those two groups, not just focus on the vaccine, but take a step back, the vaccine group versus the infection group. And that infection group is nowhere you want to be. And that, and just kind of really telling them, hey, I understand your fears. There's so much noise, but then really highlighting that infected group more it has really been helpful, having them kind of really understand, especially from someone who's seen so much in those groups. It has been very helpful, given just the confidence. And I make also I joke around quite a bit, but I even tell people if there's a 25% chance my leg might fall off after the vaccine, I'd still get it. Like, that's how scared of bad COVID infection I am. So I kind of, I really just put everything on the infection. You do not want to be in that infection group, really, no matter what. And that's been very helpful for the people who are really, truly hesitant on the fence, because just fear of common side effects and fear of very rare side effects or non-existent complications are kind of the main thing. But mean, I've told patients that if they're scared, I'll meet them at their pharmacy and sit next to them and hold their hands while they get it. I've offered taking them out for beers if they went to get their shot. I try to give some incentive. Nobody's taken me up on it, but
you're a better doctor than I am, man.
Well, I'm not. It's one of those. I'm not expecting anyone to say yes. So if they do, I might get in trouble. But if they believe me, they end up getting the shot and excitedly telling me about it, and I don't have to do those extra steps. But if they believe I'm willing to do it, I think it helps push them a little bit. We'll see if I get called out on it one day.
Dr. Klein, any thoughts on the topic?
Well, I'm looking at some of these questions here in the chat. It would be all right if I try to.
By all means, please. Thank you.
Answer those. So someone said, do you think half the dose of Moderna has more effect due to the higher mRNA amounts compared to the Pfizer dose as far as efficacy? And, that is something that I was wondering as well, that the Moderna dose is a higher dose of the mRNA and then the Pfizer. And even their booster dose, which is half the initial dose, is still a little more than the Pfizer dose. So it could be that amount of the mRNA that's being given that could account for what appears to be a stronger antibody response to the Moderna over the Pfizer.
Yeah.
And then someone asked, should breakthrough asymptomatic COVID-19 infections in the fully vaccinated be treated with monoclonal antibodies? And so that's a really good question. I would say, they'd have to meet the criteria for requiring monoclonal antibodies, which means they'd have to be in a high risk group. So 65 and older is high risk, or people who have underlying comorbidities that put them at increased risk for more severe disease. And that's a long list of comorbidities, including diabetes, hypertension, obesity. And the other important distinction is you can't give the antibodies to people who are ill enough to be hospitalized and need treatment for COVID-19. So it is that sort of, mildly ill to asymptomatically ill vaccinated people. I think it's a good idea, especially in the very immunocompromised patients.
Yeah, I think that asymptomatic incidental infection in the fully vaccinated, I think you do have to have some degree of symptomatology under the EUA to be eligible for monoclonals. But that being said, I have given monoclonals to some very high risk groups in the absence of significant symptoms, just recognizing the very high risk of progression in certain populations.
And I think the clock starts ticking for 10 days from the first symptom also. So I think you kind of need to have a symptom, because it doesn't really go from the first positive test, right, for the monoclonal.
There's a little bit of flexibility in defining that, I think.
10 days of symptoms.
Yeah.
And I struggle with that question a lot. Now, granted, I think a transplant patient, which I don't seem like that's a very different group in the immunocompromised, but I struggle a lot with vaccinated people who have a BMI above 30 or who may have some mild lung disease or so, where they're technically not high risk because they are vaccinated. Like, I almost use their vaccination status as a lower risk, almost dropping their risk a little bit early on. And that's where I kind of struggled with that decision in the vaccinated, because I view them as lower risk. But I have been, but I do discuss it now with everyone who might qualify, and then I help them choose, but I at least give them that option now. But I struggled a lot with that. If you're vaccinated, you technically are lower risk, for the non-immunocompromised people,
No, it is a different population. One question that we're seeing a fair bit of that I think would be good for us to loop back is what is we'll use a technical term, the correlative of immunity for COVID. So, for certain infections, we have relatively clear correlates of immunity, a certain titer of anti-hepatitis B surface antibody levels, for example. we don't really have something like that for COVID yet. We look at antibodies against spike protein. We look at titers against nucleocapsid protein. But we don't actually know what level of antibody it correlates perfectly with protection. We do see that there is an association, that we see that as antibody levels go up on a population level, we see fewer infections in that group. For example, following mRNA vaccination, following adenovirus vector vaccine like J&J or AstraZeneca vaccination, we see that the risks of infection increase. I apologize. Evidently, my hospital did not get the memo that I was doing a webinar today. But we can't draw a titer of anti-SARS-CoV-2 antibodies and say above this threshold you are immune, below this threshold you are not. So what can we say about antibody levels and protection from what we know from the published literature?
I mean, pretty much I just tell them more is better than less. I mean, that's really, in general terms, I think that's all we know, because we don't have those set numbers or those set cutoffs, but more than today is going to be better than having less. And that's really where I leave it at, because they oftentimes come at you with numbers. They'll get them checked somewhere. And I don't know what they mean, but having more of that is going to be better.
That seems reasonable. Dr. Klein?
Yeah, I don't think we really know what the particular cutoff is. We can't really reassure people. If your antibody levels over this amount, you're protected. The other piece that we don't know is how does cell-mediated immunity weigh into this. And it could be that plays a larger role than we realize, and that's not going to be reflected in the antibody level either. And so right now, I think we generally would recommend people not check antibody titers to know if they're immune or not, because it's hard to interpret that and give people good guidance.
No, absolutely. I think we've all been asked that question, both by patients and probably by friends and family members as well. And I've never been able to give people a straight answer to that. How about kind of the thing we haven't addressed is, like all things with COVID, plans for educational events get thrown off by actual events, meaning that in the last really week, the Omicron variant, and what role is this going to play in our vaccine plans going forward? Dr. Klein, any thoughts?
Yes, I think we just are sort of learning, how this is going to impact the vaccination efficacy. I don't think we have a lot of good data yet. One of the slides I showed you was looking at the virus neutralizing antibody titers in patients after, 2 doses, and then after 6 months and after 3 months. And you can see how there was a difference with the different strains, that there were lower levels of these neutralizing antibodies against the beta variant, for instance. And so we don't know if that's where the Omicron level's going to fall. Is it going to be low? Meaning we'll have less immunity to that as compared to the Delta. And I think those experiments are being set up in research labs right now, and we're going to have to wait for those results.
Yeah.
No more.
And one question that I think comes up a lot that I forgot to mention from the vaccine hesitant is many have this notion that natural infection is better than immunity from vaccination. That's been a little bit of a challenge also, especially with some of our younger patients. And, I think we said it might be good for some people. We just don't know who. But I also tell these patients, I've never seen a vaccinated breakthrough infection lead to death in a 40-year-old. I've seen a 40-year-old who had COVID in the winter die of COVID in the summer. And I just from those stories, natural infection might be good for some people, but we can't identify who that's good enough for how long. And just drawing on that, I think most of us can recall patients who died of new COVID infection at some period of time after their first one, but I've never seen a young, otherwise healthy 40-year-old die of a vaccinated die of COVID following vaccination. So that's also kind of been a challenge of how do you tell them that, hey, natural immunity is not superior. So that has been a barrier that I forgot to talk about too much earlier, but.
And I think we're starting to get hard data to back that up too. Early on, there was a study called the CHARM study, which was done by colleagues in the Navy when I was still active duty. I had nothing to do with the study, but I wish I had, because it was an amazing study looking at the impact of immunity in a Marine Corps recruit population. This was led by Dr. Andrew Letizia, a Navy infectious disease physician with colleagues from the Naval Medical Research Center. And so, kind of the definition of the young, healthy population, right? 18 to 21, mixed gender, in good enough physical health to join the Marine Corps, right? And looked at impact of prior COVID infections and risk of getting reinfected during their time in basic military training, which is up to about 3 months or so. And they identified about a 85% reduced risk in that 3-month window, right? But we've had later data showing that 3 months of protection is pretty reliable across populations. After 3 months, it becomes very variable. And just like you're saying, there are some people whose immunity lasts much longer. There are other people whose immunity wanes quite rapidly. And clearly, this is not sterile immunity. This is not varicella. This is not measles. This is something that wanes very much like influenza, where you can get it over and over again, and that protection is simply not reliable. And that's even before we get into questions of variants, of beta, of delta, of mu, of now Omicron. And knowing how that's going to play out is important. I think the way you put it is exactly right, that the risk of breakthrough infections from natural immunity is at least double and probably greater than that after vaccination. I believe there's one recent report, and that's probably pretty close to what most of us have seen clinically. But of course, the point of vaccination is not just to reduce all-cause infections, it's also to reduce the severity of infections. And the severity of those breakthrough infections following vaccination are also much lower than the severity of breakthrough infections following natural infection. Certainly curious if you feel any differently about that. Dr. Klein, Dr. Cabaza?
Well, I'll let Dr. Cabaza comment first.
Yeah, I'll say just anecdotally, that is what we see. We see a lot more people in the hospital who have breakthrough COVID from who had natural infection in the past than those with breakthrough infection from vaccines, I think, across the board. And certainly, a lot more comparatively severe infection in breakthrough of naturally vaccinated compared to those with naturally infected compared to those who are fully vaccinated. So just anecdotally, that does make sense. That's what I'm certainly seeing more, and that good study supports that. And it's been tough because this narrative has kind of spiraled a lot in the misinformation circles that natural infection is superior and that it's better, and once you're infected, you don't need it. And I've just seen people die who had young people who held on to that as well. Granted, I'm not sure how many of them would have gotten vaccinated anyway, but I imagine there's a subset of people who would get vaccinated even with natural infection prior. I think we should try to reach somehow, but it's been a challenge, and that was that other kind of barrier, of that group that I totally left out, of just the natural infection group that, are just holding on to this notion. Yeah, but anecdotally, from what I see in the hospitals and the ICU, it's certainly natural infection seems to be not as strong, the immunity from it.
Yeah. In fact, there was a study I saw. I can't remember if it was Tennessee or Kentucky, but they had good state level data. And they looked at people who had prior infection, and then they compared going forward following their state data and looking at reinfections. and then looking at their state vaccine registry data. And they saw that people who had been vaccinated after the earlier infection had lower rates of reinfection.
Yeah, I think it was Dr. Fauci who said that vaccination after natural infection probably makes you about bulletproof, was the term I believe he used.
Well, at least for a period of time, right?
Exactly.
We don't know how long that lasts.
Exactly. And that actually, I think, relates to another question in the chat. Are we looking at a scenario like with the influenza vaccine, where every year we get our influenza vaccine and our COVID vaccine at the same time? And I'm going to hypothesize, yeah, maybe. And I don't think that's bad. I know that Moderna and some other manufacturers are actually looking at a combined single dose or single injection vaccine that would include influenza and SARS-CoV-2 in it, which would be enormously convenient. Whether we need it, I don't know, but I suspect that there's a good chance of that.
Right.
And this last question here is a great one about boosters following a breakthrough infection.
Yeah.
And I'd be curious because about how you both approach it. Certainly from my end, again, I'm back in that theme of let's get as much immunity as we can. So I tell people after your natural infection was probably a booster of sorts, and after 3 months, get a booster the easy way, and then kind of call it at that. But I'm not sure the data there or kind of what how you may practice that. But
I think that's a very reasonable approach to wait 3 months and then give a booster.
Yeah, no, I completely agree. CDC, I believe, has said that you can get vaccinated once you've recovered from your acute COVID and are able to come out of isolation. So they don't put a timeline on that in their guidance, but I think it's okay to wait a couple months. 3 months seems like a perfectly rational period of time based on what we know. I wouldn't wait much longer than 3 months, though. I would say when you're feeling better within the next 3 months, please do so. And I think it is the top of the hour, and I think we are out of time. So first of all, Dr. Klein and Dr. Capaza, thank you so much for taking the time today to share your wisdom, your expertise, and the data with everyone. And thanks for letting me join you and talk to you. I know one of the pleasures of moderating these things is I get to talk to people who are much smarter than me, and I enjoy that a great deal. So thank you both for your time. And thank you again to everyone who's listening. And thank you to the CHEST staff for letting us put this together. Everyone have a wonderful rest of your week. Happy holidays and stay safe.
Thank you. Good night, everyone.
Bye-bye.